Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jacqueline Meredith. This episode is our second of two sets of expert answers to your questions on PrEP and cisgender women. I'm joined by Dr. Meredith Clement, Associate Professor at Louisiana State University in New Orleans, Louisiana, and Dr. Whitney Irie, Assistant Professor at Boston College, Department of Social Work in Brighton, Massachusetts. For the full online educational program, including video roundtables, downloadable slides, and other podcasts in the series, please visit the link in the show notes for this episode. Now let's get started. So we've had a number of questions come in already, and we'll do our best to answer as many as we can. I'm going to start with our first question. First off, with only having 15 to 20 minutes to complete an appointment, many providers are pressed for time. So how can providers best fit the conversation about PrEP with their patients in this short period of time? We'd love to hear responses from both of you. So let's start with Dr. Clement.
Yeah, sure. I mean, the point is very well taken. We are always in a hurry. We have so many things to do, so many competing priorities. I totally understand where providers are coming from. I think knowing that it actually doesn't have to take a lot of time to talk about PrEP. PrEP is one of the easiest things we do for patients. It can be as simple as like, what do you know about PrEP? Are you interested in learning more? And kind of starting that conversation. Actually, one thing I've found with patients is maybe they just want to know about it initially, and they're maybe not even ready to take that step. So even at the initial visit, I think the expectation is just doing some education, telling them a little bit about how it's safe and it's effective and it's well studied in women, and then giving them time to sort of sit on that and think about it. And they might come back to you. I've had this happen a number of times. They come back at that next visit like, oh, you talked to me about PrEP. I've thought about it. I did some of my own research. I'm actually really interested. But knowing it can even start with like a 15 to 30 second conversation, even as they're getting on the table to do the physical exam or something. So working it in, knowing it doesn't have to take a lot of time, but opening up that conversation, I think is a really important initial step. Whitney, do you have more to add to that?
I could not agree more. In fact, a study that was published last year in 2022, Dr. Scott and Dr. Shanika Hull found that for women in DC, Black cis women, one of the factors that was significantly associated with them starting PrEP was having a prior conversation with their medical provider about PrEP. So just like that initial brief conversation, that brief PrEP counseling, and then they came back around to it. And so I think really part of it is like honoring that, you may not have enough time in that space. If you as a provider plant that seed and you are a gardener and you're thinking like, I'm just going to plant the seed and I'm going to give it some time to sprout. I think that's very important. It also helps the provider be an active participant in respecting the decision-making process of the women that you're caring for. And so absolutely, even if it's a brief amount of time, give your patient that and soon it might get some traction.
Yeah, you might grow a plant. I love that analogy. No, they will blossom, right? That's a better thing to say. But no, I love that analogy. And one thing we found with our work with some women here, talking to them in New Orleans, is that providers just aren't having these conversations. And so I think I like to reframe, like, we've done so much work to talk about barriers and barriers and barriers. Like, what are we doing to overcome those barriers? And I think one of the easy solutions actually is just starting the conversation more frequently. And it doesn't have to take a long time, and it likely will not take a long time, especially that initial conversation.
Thank you both for those responses. And this links to your response from Richard and also Bellamy, who asks, when patients do want to do their own research, when you bring that up in conversation, do you have a good resource to share with them that is not very overwhelming for them to look through? Or are there specific training or resources that you know of that you could provide to patients or clients about PrEP?
Yeah, I can jump in quickly. I'm sure Whitney has more to add, but the CDC website has really fantastic information. The Well Project has an amazing video, a woman talking about why PrEP is right for her. There are a number of resources. I can look and drop some more in the chat, but certainly I think the CDC really, the Her PrEP campaign is kind of has really great information and good visuals too.
I agree. I was going to mention Her PrEP and the Well Project. And also, I'm not sure what state Bellamy and Richard are from. So there's some statewide campaigns in certain spaces and citywide. I know Chicago has some things going on, San Francisco, of course, New York, and I'm sure Atlanta. Speaking of Atlanta, Sister Love has a lot of PrEP information on their website that if you want some materials that's designed and highly inclusive of women of color, Sister Love might be a good resource for that as well. So there are a lot of spaces that are making a concerted effort to produce resources, educational resources that are accessible in different levels and experiences of health literacy around PrEP. And so I do think there's an abundance of options out there, but Her PrEP and the Well Project are a great place to start. And I will also say Sister Love is a great place to start as well.
Great, thank you. And I have a question from Asia about tips of how to best communicate PrEP for heterosexual women with partners. What are some, known challenges or ones that you've experienced or have read in the literature? And what are some solutions that can overcome some of these challenges?
I'll just jump in. I recently published an article about among Black cis women confidence discussing PrEP with their partners. To date, a lot of the PrEP framing has been around, it's an independent choice and, you're doing this on your own. You don't have to discuss this with partners. And I love this question because this highlights the reality that women actually are people. Folks just in general want to discuss it with their partners, no matter how serious the romantic commitment is or how casual the arrangement is. There is this desire to have some level of transparency about it or have this discourse. And what I found is that if the cis woman especially has a greater amount of efficacy around just like their knowledge of it and where it fits into their prevention landscape and their health experiences, they will feel much more confident and comfortable discussing it with their sexual partners. I do want to bring up that there's been some great work out, and I think it was Dr. Willie at Johns Hopkins around strategic safety or safety strategies for women who are experiencing IPV and how we can help ensure that there are interventions and role-playing interventions so that women experiencing IPV, should they want to disclose or discuss their PrEP use with partners, they have some measures in place that helps them feel confident, comfortable, but most importantly, safe, considering those sort of power dynamics and conditions. And, so there's some work that's being done in that space with regards to women experiencing IPV, but also from my work, increased confidence and self-efficacy is critical because that actually helps moderate the anticipated stigma that women are feeling might come from their sexual partners. So they already feel like, well, this is going to be stigmatized or not. The norms around it are not going to be acceptable. However, when they feel much more knowledgeable and feel more confident around their knowledge of PrEP, that kind of reduces their anticipation of that stigma and helps kind of facilitate that discussion.
Yeah, and just kind of latching onto what Whitney said in terms of the self-efficacy and reduction of stigma. Scott et al. Just published an article about, talking about peer navigators to kind of help reduce some of that stigma. I know that's not, possible for every clinic, but I really think navigational services can be so critical in making or breaking a PrEP program. So if you have the resources to put towards navigational services, but particularly peer navigation, like somebody who looks like the person, the patient talking about, why I'm on PrEP and why it makes sense for me and why it could make sense for you too, I think really goes a long way to reducing stigma and enhancing self-efficacy.
Thank you. That leads to another question about how best to leverage clinic staff to improve PrEP uptake and persistence. And Dr. Clement, you mentioned PrEP navigators, but are there other staff that can help with improving PrEP uptake within a clinic? And if so, who are they and what can they do?
Yeah, I mean, this is all hands on deck, and we can sort of shift to talking about long-acting injectables and how the rollout of those has been sort of fraught with staff shortages. That's maybe a separate conversation, but I do think that it takes the whole clinic staff to make these programs successful, starting with the front desk staff, who is the patient's first encounter or first point of access, and ensuring that they know what PrEP is and that there's no stigma when they ask about PrEP or say I'm here for a PrEP visit. To the nurses who kind of help with the blood work or help with the injections, and the providers and the navigators. But I do think it's kind of, you have to be all in. We have rolled out a same-day PrEP program within our sexual health center. So it was asking folks who are so used to just, gonorrhea, chlamydia, syphilis, to bring in a conversation about HIV and start counseling and prescribing PrEP. And I think, at least at our clinic, people recognize the importance. They've diagnosed enough HIV infections in that clinic that they understand that this is a need here. But yeah, that was our nurse practitioners and our nurses, everyone kind of joining forces to make same-day PrEP successful.
Dr. Irie, did you have anything to add about other ways that people can leverage their clinic staff to improve PrEP uptake?
Yeah, I have to echo Meredith's sentiments. It's a team effort. From the patient perspective, if you were to do some patient journey mapping, every interaction that they have in that space should be an interaction with someone who's a PrEP champion. That means your whole team should be a PrEP champions. And if there's some discomfort around that, that means that there's an opportunity to educate your team about it and what it means. If you are a clinic that, does bacterial STI testing and folks are calling to, give people their test results and everything of that sort, that PrEP can be a conversation integrated within that. Again, it doesn't have to be this drawn out PrEP counseling, but those short moments of, here's some other prevention options, or while you're picking up your treatment or when you come in for treatment for this, you might consider talking to the provider about these options, and just kind of normalize it and routinize it as much as possible. I also want to stretch a little bit and say, if you are a clinic who knows that your patients go to certain pharmacies, it might be important, if you have the time and capacity, to check in with the pharmacy managers at those sites and learn, should my patient come to you, what's the process for them getting PrEP? Are there a lot of hurdles? Is there anything that they can do before they get there? Because I think once they leave the clinic space with that prescription, we see there's a huge drop off. You get the prescription, but it's not getting picked up, or just the challenges with it in certain states and a lot of different states due to policy issues. And so it might be important to be thoughtful about that as well.
Thank you. And we have several questions about different PrEP options that I might start off here with a question from Mauricio. Why is on-demand PrEP or 211 PrEP not recommended for cisgender women? So Dr. Clement, can you comment on that?
Yeah, Whitney and I have actually talked about this a great deal because we think it's very unfortunate that it's not recommended. I think it would have huge uptake if it were. I see women in clinic all the time, and I talk to them about PrEP, and their kind of response is, well, do I have to take it every day? I don't want a daily pill. I don't even have sex that much, but they would want that reassurance or protection when they did, but that trade-off of taking a daily pill is just not worth it for them. So we think it's unfortunate, to say the least. The why it's not recognized in the CDC guidelines for cisgender women is because it just really hasn't been well studied. Linda Gale Becker and colleagues published a study, the ADAPT Cape Town trial, HPTN 067, I believe, where they looked at like time-driven versus event-driven versus daily PrEP. It was not powered for efficacy to look at differences in HIV incidence, but it looked at like coverage of sex acts based on the sexual diaries that they got from the surveys they administered. And so what they found is that daily PrEP, the the time-driven and the event-driven PrEP just did not give us good coverage. The adherence wasn't there. And actually they did happen to see 2 HIV infections in each of those arms versus none in the daily oral PrEP arm. So I think that kind of limited our enthusiasm for studying it further. That said, there is more and more data now that it is a viable option in women because of it, or it could potentially be a viable option in women, because more and more studies are coming out that support kind of more of this, like, systemic coverage is what we need. It's the systemic levels of PrEP rather than the levels in the cervicovaginal tissues. Again, this is sort of a complex topic, talking about all the pharmacokinetics here. But just all that to say, on-demand PrEP has really not been well studied. The one study that wasn't really even on-demand PrEP, it was a pre-dose and a post-dose. The study by Linda Gale Becker that I was mentioning earlier did not lead to excitement for further study. But I think we may be at a turning point now where we're getting more data on the viability of the option in cisgender women. So maybe it's opening the possibility for that option in the future. That was a long-winded answer. I don't know, Whitney, if you have anything to add.
I don't have any more to add. We discussed, I think that it's a social justice issue. I think that it's understudied, and it's understudied just as a lot of other critical issues and possibilities to counter those issues for women when it comes to medicine. So, hopefully there can be some more discourse around it, because women deserve as many options as possible.
And just to let you know, like, as providers, we like to say, this has proven efficacy. This will work for you. And because we can't definitively say that about on-demand PrEP for cisgender women, who are having receptive vaginal sex, we don't tell them to use it, but it needs to be studied. We really would like to have that option to be able to tell women that it would be effective.
Thank you. Our next question is from Ashley, asking about what are the contraindications for some of these PrEP options. And I think just the next step would be interesting to say, how do you communicate that with patients? Is that something that is asked often? Is it something that you introduce right at the time of talking about the PrEP options?
Yeah, I mean, the great thing I think about these drugs are that there are not a lot of contraindications. We can prescribe them to most people who walk in the door. So long-acting cabotegravir, there are a few contraindicated medications. So it's mostly anticonvulsants or seizure medications. And then the rifamycin class, rifampin and rifapentine, if they're on those, for like mycobacterial infection. Again, this is not going to be a ton of the patients we see. And some of those mycobacterial infections, they're not on those indefinitely anyway. So the drug-drug interactions are minimal with cabotegravir. Obviously, for all of them, people need to be HIV negative. So HIV infection would be a contraindication. Prior hypersensitivity would be a contraindication. And then in the study for cabotegravir, we did exclude anyone with buttocks implants or fillers. And so I would have a lot of hesitation administering cabotegravir as a gluteal injection to somebody who does have those. We really don't have any data to know that that's okay. For daily oral PrEP, TDF, FTC, the drug-drug interactions are pretty minimal. You don't want to give it to anyone who's on orlistat. They're just not going to absorb it. There are a few contraindications like hepatitis C drugs. So just and some other antivirals just to be aware of, but I think it's going to be few and far between the folks who are on those. And then the other contraindication to TDF FTC would be a creatinine clearance less than 60. And so, we do check for baseline renal function before we start anyone, or I guess in the case of same day PrEP, as we're starting someone on TDF FTC. And then in terms of side effects, you are having a conversation with folks about the creatinine clearance, the small decrement that we tend to see in renal function. And I usually offer reassurance that if you're less than 50 years of age and your baseline creatinine clearance is greater than or equal to 90, you have pretty healthy kidneys, that decline in creatinine clearance is going to be quite minimal, very minimal, clinically negligible even. And if they don't fit those criteria, if they're 50 or older, or their baseline creatinine clearance is less than 90, then we monitor them more frequently. We monitor them at baseline, and every 6 months. You could even check a 1 to 2 month creatinine clearance if you felt uncomfortable, just to see that if there was an immediate impact. And then for the bone mineral density, the way I counsel patients is that the decline is also very small, about 1% decline in bone mineral density of function. It's reversible when folks come off of TDF FTC, and it's never been associated with anything clinically significant like fractures. And then I guess the last thing I was going to add is it's just a reason for, if patients are smoking cigarettes or they're vitamin D deficient, it's a motivation to stop smoking or to replete vitamin D. So that's how I tend to talk to my patients about TDF FTC and cabotegravir. And I really do sort of emphasize that they're both well-studied, safe, effective medications.
Thank you. And I just want to piggyback that question with a question from Michael. We've talked about side effects. Anything different or any different approach you would take for someone that is pregnant or is planning to start a family and considering PrEP?
Yeah, sure. I think we've used TDF FTC for a long time in the setting of HIV infection. And now since 2012 for PrEP, we have more than a decade of experience with TDF FTC for PrEP. And we feel really comfortable with its safety profile in the setting of pregnancy. For CAB-LA, we don't have that data. There were a number of pregnancies in HPTN 084, which was the large clinical trial that showed that cabotegravir was superior to TDF FTC for cisgender women. There were a number of pregnancy events. None were associated with congenital anomalies in CAB-LA. And we're starting to see more data for cabotegravir plus rilpivirine for treatment of HIV infection. And so far, nothing concerning is emerging from those data either. I would just counsel that we have very limited use, maybe for the right patient who really, really wanted to avoid daily pills, but and was interested in injections and interested in PrEP. I think you can have that conversation about cabotegravir long-acting. But I guess generally, I would feel more reassured with the use of TDF FTC.
Thank you. So historically, it seems as though the marketing for PrEP has been in men who have sex with men. And Bellamy has another question. Do we have good examples of marketing towards cisgender Black women? And if so, what are they? And can you share them with the group?
Yeah, thank you so much, Bellamy, for your question. I think that this is an important topic because I don't think any group of individuals want to be kind of like targeted for, some sort of medication or treatment or things of that sort. And what we do know from focus group data, Black cis women stating like we don't see ourselves in the advertisements, and we don't feel as though it's for us because we're not represented in this space. I think that has been kind of carried and interpreted as, okay, we need some, like, I'm just using certain language intentionally for a point, but we need some targeted marketing strategies and things of that sort. And the reality of it is that there are communities of Black cis women who don't want to be targeted. If we were to step back and look at these narratives and this qualitative data again, what was being asked of communities of Black cis women is wanting this marketing to be inclusive of them. And being inclusive is different than targeting. Being inclusive means that should you develop a PrEP campaign, it would be great to see a Black cis woman that is clear phenotypically that they are Black women because of their skin complexion, included with also maybe a Latina woman or maybe a white woman or maybe, Native trans woman. It's wanting to be included in this discourse and included in the marketing. And I think that we have some ways to go with that, because part of kind of like the health promotion response to the data that we receive from Black cis women has been let's target. And that has not, there are some studies that show that has not necessarily been received well, because it becomes, well, what's wrong with us? Why are we only being targeted? What about, our other groups of women who share this space with us who are not Black and who are not cis and things of that sort? So with that said, I urge folks who are developing materials and who are thinking about it in this way is, what does it mean to shift from targeting to being inclusive? And I think that that's what's going to make a lot of these PrEP awareness campaigns and efforts much more successful. And, what are some good examples of that? Someone put a campaign in the, that could probably be shared in resources, but I do think that some of the citywide campaigns have some very inclusive work that's being done. I think Chicago has some great work that's inclusive of a lot of different women, and it also represents Black women. I think New York has some great materials that's been developed. The Risk to Reasons campaign that comes out of ViiV Healthcare has some beautiful, just amazing marketing material that's inclusive of all different groups of Black women, and that was highly favored and well received. That's some things to think about. And those are also some resources in order to answer your question. And I hope that helps.
And I think I may have misspoken earlier if I said her PrEP. That's the implementation strategies development. I think I meant She's Well, the She's Well campaign from the CDC to be inclusive of cisgender women is one example. Stay tuned for a social media campaign in New Orleans that is currently in development that is more inclusive. I think that we as providers and researchers and hopefully kind of folks in the commercial sphere or space are starting to see the light that the initial rollout of PrEP advertisements was not inclusive and it was stigmatizing. And so I hope there's starting to be a shift in the marketing.
Thank you. Our next question is from Linda Liz, asking, what has been your biggest challenge to link a patient in PrEP?
That is a great question. I think the biggest challenge is stigma. I think we still, I'm in the Deep South on a day-to-day basis. We deal with stigma. I think that ties into the risk perception too. They think those are very related barriers, but it's hard to have a conversation. I think what is really challenging to me actually as a provider is what I see is the stigma that prevents people from going on PrEP is the same stigma I see once a woman has tested positive and she's in your office and she has this new diagnosis and she's in tears. And then you try to counsel her, it's going to be okay. This is not, this is something we can totally treat and deal with, and U equals U, and you have all those conversations. And then this has happened to me a couple of times recently. You see her for follow-up. She still hasn't told any of her family members. She's still living in total isolation. She still doesn't have a support network. But I think that's a really big challenge, is like the same population that is in my office grappling with this new diagnosis is the population that doesn't want to talk about HIV because of the stigma that is totally pervasive throughout the Deep South and actually in all parts of America, to be honest. And so overcoming that, I think we've just spent the last 50 minutes talking about normalization and normalization and normalization, but having this conversation with everyone, talking about PrEP is for everybody. PrEP should be, part of our prevention toolkit. PrEP is important for your sexual health. All these conversations, I think, gradually can kind of chip away at that pervasive stigma.
I completely agree. It's the tango dance between low risk perception and stigma. I mean, they're a couple, they're a pair. And the music they're dancing to is this idea of disassociation, like not wanting to be associated with, HIV or, these sort of topics. Thank you for sharing that, because I thought that was an excellent example of how much social norms and stigma are important for us to really work to address. The World Health Organization has no shortage of materials really centering stigma reduction as the strategy necessary in order to, reach those in the HIV epidemic numbers, or in order to do PrEP scale up. Like, World Health Organization is very much so deeply committed to stigma reduction strategies. And I think that that's something that we need to also embrace. But part of the challenge with embracing it in the States due to our policy landscape is that we have some ruptures in some of the fundamental systems that actually perpetuate the stigma, which is sex education. we don't have universal sex education, universal comprehensive sex education to this date. And if you were to look at the states that have abstinence-only education or limited forms of sex education, I'm sure you can map on there the concentration and the prevalence and the incidence rates of HIV for a lot of different communities, especially impacting communities of color or African-American communities, Black American communities. And so it's this real entanglement that is clear, but it's rooted in policy. You know, the stigma comes from conversations that have not been normalized, and that comes from being in spaces that continue to, you know, ensure that we're not providing proper education and proper spaces for our youth, even our adults, and even our providers to have these conversations in a meaningful way. And that leads to, you know, a woman coming into space and wanting to immediately disassociate with something that maybe more education, normalization, and acceptance could actually help them say, you know what, this is important for me to be proactive about, or this is part of my health. Everyone's talking about this. A ton of people are having sex, you know, so this is something that I might want to be proactive about. So I couldn't agree with you that stigma is huge. And part of that, it feeds into risk perception, which is all related to disassociation and lack of comprehensive sex education.
Absolutely agree.
We have a few more minutes left. And I think one of the last questions that I had has to do with other strategies that were not yet discussed. I know you guys talked about tons of different strategies to overcome PrEP barriers in cisgender women, but just before we end, are there any key ones that we should share with our learners that could be helpful for them to implement at their clinic or at their practice site?
Yeah, something that I'm not sure we explicitly stated this as a strategy is that the low barrier to care model is important. So, you know, just ensuring that should they want to use PrEP, just like, how can we make this as easy as possible, you know, as smooth as possible. But also the peer model is very important. I mean, we're talking about stigma reduction. We're talking about normalization. A lot of the barriers are, I wouldn't say it might not be the amount of barriers, but the strength, like the stronger barriers that are really like heavy duty, like mountains of cement barriers are socially embedded. They're the social barriers. And so if you want to think about that in your clinic space, you want to think about how much of my clinic staff are socially embedded in, you know, in the communities that the women we serve reside. How can we be, you know, ensure that we are much more inclusive of community members in care delivery decision makings? And how can we also get support for a peer model for PrEP linkage or for PrEP education? Because we want to start implementing real substantial models that operate on the social level. And we want to do that with a community-centered approach. And I think that this is the time that clinics are kind of becoming much more empowered and knowledgeable and in some ways capable of kind of embedding those kind of models of care into their practices. I think that that's the direction to go.
I agree. And I just want to say, I'm so glad we're ending on like positive note of like, okay, there's all these barriers, but there are also solutions and there are strategies and we can move this in the right direction. And I think I agree with Whitney, like we move forward and I think education is key. I will say in New Orleans, where we have some educational initiatives to train PCPs, to train GYN providers to prescribe PrEP. I know in Alabama, they're focusing on training family practice residents, family medicine residents to prescribe PrEP. There's a lot of work in Georgia among the family planning clinics to prescribe PrEP or to train providers to prescribe PrEP. And so I think education is really key for everybody, for providers, for patients, for the public, for everyone. It'll go a long way to overcoming some of these challenges, reducing stigma, and just enhancing conversations that we can have with our patients. So just to latch on to everything Whitney just said, which I totally agree with too.
Thank you, Meredith. I did want to add that there's this other initiative, depending on, you know, this might be more or less salient depending on the states represented in this webinar right now. But the Faith in HIV initiative is great. And Dr. Allison Matthews, she was at UNC Chapel Hill, but Dr. Allison Matthews is leading it with other religious and faith-based community leaders. And I think that that is a great a great initiative. They have a lot of resources. I think that it's worth looking at because it goes hand in hand with, again, what we're talking about with regards to stigma reduction, normalizing. And for some communities, spirituality and religiosity are significant when it comes to their health decision-making, especially around sensitive topics when it comes to relationships and sex and sexual health. We want to ensure that we're being inclusive of other spaces in that way, if not just to educate ourselves about the role that faith and religiosity and spirituality has for a lot of communities when it comes to HIV prevention and HIV treatment and care, the whole continuum. So yeah, that's the Faith in HIV initiative is a great resource for folks if you're interested. Allison Matthews.
Thank you for mentioning that, Whitney. I didn't know about that, but I remember Allison from when I was in North Carolina, and she's fabulous.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder to view the full Paths Forward in PrEP, Overcoming Barriers to PrEP Engagement in Principal Populations program on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.